G'day everybody, my name is Elliot Waters and you're listening to the Dysregulated podcast. As always, thank you for tuning in. If you're enjoying the show, feel free to like, subscribe and share it around with your mates. And today's episode is all about treatment-resistant disorders. What's the story when you're doing everything the doctor or the psychologist says and it just ain't working? Well, we're going to dive into that today and we're going to have a look at the implications for being classed as treatment-resistant as well. So before we get into it though, into the meat of the episode, we really need to get some definitions out of the way. So we're going to look at two. We're going to look at the psychiatric definition of treatment resistant, and we're going to touch on briefly the psychological definition of treatment resistance as well. So there is a real clear difference between both definitions, and it's all about who carries the burden. So let's do the psychiatric definition first. It's something like this. Treatment resistance comprises the trinity of establishing, first off, the correct psychiatric diagnosis. Yeah, that's pretty important. And then prescribing adequate treatment, which is in terms of dosage and duration. So we need to get the right medication and we need to actually give it a bit of a go first before we throw it in the bin. And then after doing all of that, we still get inadequate symptomatic response. Bad news. So let's look at the psychological definition and see how it differs. So this is straight from the American Psychological Association website, a very powerful body in the field. This is what they have to say. So it is reluctance on the part of the individual to accept psychological or medical treatment or to comply with the therapist's or physician's prescribed regimens. Already we're seeing a difference here. In psychotherapy, treatment resistance is the lack of a positive response by a client to the techniques being used and results in a rupture of the therapeutic alliance, which requires the use of other strategies by the therapist to repair said alliance. Examples of treatment resistance include non-compliance with assignments, extended silences, seemingly pointless debates about the therapist's approach, suggestions, and interpretations. So in that first definition, the psychiatric definition, it's all about putting the blame on the physician and the medications that are available to us. It's their fault. But with the psychological definition, it is our fault. It's all about the individual not accepting treatment. So two very different definitions there. And I don't particularly like that psychological definition. I think it's wrong. It is not the individual necessarily who is being resistant. And really, a good therapist should be able to cut through any resistance coming from the individual, in my opinion. Okay, maybe that'll change when I'm out in the field and I'm coming up with some people in therapeutic alliances and they're not quite engaging with what I have to say. But as it stands right now, as someone who's been a client many times with many different people, I think a good therapist should be able to cut through. So today, though, we're going to focus on the medication treatment resistance side of things. And to do that, we need to have a look at the parameters around what actually constitutes treatment resistance. And as we'll see, it is not very clear. So in general, for mood disorders, in anxiety disorders, and in schizophrenia, the standard measuring stick is leveled at the inability of two adequate medications to significantly improve an individual's prognosis. Now, this is accounting for appropriate dosages and trial periods lasting for at least 6 weeks. That's from the World Psychiatric Journal. Now, there was an author, Nemiroff, I hope I got his name right, in his published work, Prevalence and Management of Treatment-Resistant Depression. Most of the research, by the way, is around depression, but anyway, we'll press on. He states that stage 1 treatment-resistant depression is a failure to respond to one adequate trial of an antidepressant. So I don't know about you guys, but that's a lot of us. And stage 2 being a failure to respond to 2 antidepressant trials. And I still think that would be a lot of us. Now, often you can see little improvements with a significant response effect occur short term. But then you see a swift return to the depressive baseline. So, for example, let's look at me. You may remember more recently I tried a new medication, Wellbutrin, or in Australia it's called Zyban. Its generic name, bupropion. Now, I had a massive boost for about 5 days when I first started taking it, but then I receded back to baseline. So, when we talk about response, we need to sort of define that as well. So, what metric are we using to define response and to inform whether medications are actually working or not? So, again, in major depression and in generalized anxiety disorder, response is usually defined as a 50% decrease in symptom severity, but has also been defined, as I've seen in my research, as a 25% decrease in patient selection for trials focusing on treatment-resistant depression. So they lower the bar to get more people into the research trials. In obsessive compulsive disorder, which of course is a subcomponent of anxiety disorders, it is usually defined as a 35% decrease in symptom severity. And in schizophrenia, it is defined as a 30% decrease or a 20% decrease in treatment-resistant schizophrenia. Okay, so what does that all mean? Well, what it basically means is there's different metrics for every single disorder, and really it comes down to the physician or the psychiatrist as to where they put their measuring stick. That's what it means in the real world. It is very much a case-by-case basis. So using these definitions and these parameters, we would find that many people, and I'm sure many of you listening would say, hey, this is me, would find themselves in the treatment-resistant zone without knowing it or without it being specifically mentioned by a doctor. Now, this is me. I've been in the treatment-resistant zone, as we'll see in a minute, for a very long time, and only until recently have I really thought of myself in this space, and it hasn't actually been put forward by a doctor yet. But as you will see with some of my compelling evidence I'm about to produce, I definitely fit this zone. So in my personal experience and in my research and in talking to people out on the road and stuff, I'd say most people don't get lucky the first time. And I think it's very much for most people a necessary part of the journey to trial and error and find the right type of medication. No one size fits all, unfortunately. So as I said, only recently did I start to see myself as someone who is treatment resistant, even though I have met this criteria literally for over a decade, probably more, probably closer to 15 years. And this is why. So let's go through my medication list over the years and see how many different types of meds that I've tried, because I'll tell you what, there's a lot, so hold on. All right, so first off, let's look at the selective serotonin reuptake inhibitors, usually the first port of call when seeing a doctor and getting medication. So I've tried escitalopram, which is Lexapro, and fluoxetine, which is Prozac, the original. Next are the SNRIs, the serotonin norepinephrine reuptake inhibitors. I've tried venlafaxine or Effexor and desvenlafaxine, which is Prestique, which gave me crippling anxiety, that last one. Ugh. Next are the NDRIs. We've got norepinephrine dopamine reuptake inhibitors. I've tried bupropion or Wellbutrin, Zyban, which I mentioned before. Mood stabilizers used for bipolar, I've used lithium. The benzodiazepines, which are the anti-anxiety drugs, I've used diazepam or Valium, temazepam and lorazepam, and that last one actually put me in a hospital. Really good stuff. The stimulant medications that we use for ADHD, Ritalin, dexamphetamine, and currently using Vyvanse, which is lisdexamphetamine, which is a prodrug of dextroamphetamine. So really what it is the long-acting version, which I actually find works, which is good. Beta blockers. This is all about calming us down, turning down the dial on our adrenaline. I use propranolol, which, maybe works a little bit, but, I wouldn't say it's life-changing. The antipsychotics, I currently use quetiapine or Seroquel and olanzapine, also known as Zyprexa. And further to them, I've also used pregabalin, which is similar to the benzodiazepine class, and also Viagra, because you use all these medications and certain things don't work like they used to anymore, and melatonin for sleep. So if we count them all up, there are 16 psychoactive medications that I've tried over the years, and I tell you what, we still haven't found the right mix. So I am definitely treatment resistant. So remember, the metric that we're using is 1 to 2 medications, if they don't work, you're treatment resistant. I've used 16 psychoactive medications and they're still not working like I would have hoped. So there you go. I am definitely classed as treatment resistant, even though no doctor or psychiatrist or even psychologist for that matter has actually said, Elliot, you are treatment resistant. We need to do something new. So this begs the question, what do we do if we are deemed treatment resistant? Well, if you're just seeing a GP, definitely ask for a referral to a psychiatrist. Definitely. They are the experts when it comes to this stuff. And if you are deemed treatment resistant, well, really your GP should have already sent you to a psychiatrist. But if they haven't, get the ball rolling yourself. And I would also say if you're not currently engaged with a psychologist or a clinical psychologist, then that should also be viewed as a high priority, because usually, generally speaking, although of course this is very individual, but generally speaking, attacking this thing from both sides is the best way to a good prognosis. Now, before new treatments are introduced, a review of the current treatment regimen should be undertaken and all the extra peripheral stuff as well. So this is from the Mayo Clinic. This is what they have to say about these things. We need to look at your life situations that might be contributing to your mental health concerns. Are there any life things going on, stressors that maybe need attending to that are contributing to being treatment resistant? You know, if you've lost your job and you've got financial pressures, that isn't really a psychological or psychiatric problem. That is a real life problem, and you sort of need to address that before these medications can really do their thing. We also need to consider your response to treatment. Now, so we need to actually look at these things. Look at the medications. Why didn't they work? Have you used psychotherapy? If not, why? And if you have, why is this particular type maybe not working? As we'll see in an episode soon, depending on such things as left brain versus right brain, some psychotherapies work better than others. And medications are no different. So for example, desvenlafaxine, Prestige, I said earlier, caused me great anxiety. Maybe that needs to be investigated. Is there a norepinephrine thing at play, and is there a medication that might be able to help more? What we also need to do is review all of the medications you're taking, all of them. So this includes non-prescription drugs and herbal supplements. Let's have a look at everything we're consuming that's in pill form and see what they might be doing, what part they might be playing. Because of course, like everything, this needs to be a holistic approach. Next, we need to discuss whether you're taking your medications as prescribed. Now, for me, as someone with ADHD, with no routine, everything's all over the shop, my life is chaos, very frequently I do not take my medications as prescribed. Now, I'm not talking having too much, I'm talking about not at the right times with the right intervals between dosages, etc. And depending on the medication, that can be a huge, huge factor at play here when it comes to treatment resistance. We also need to consider physical health conditions. Now, this is huge. This is huge because a lot of these can worsen depression. And I'm talking in particular thyroid disorders. I think I read the other day up to 25%, that's a quarter of all depression presentations are caused by thyroid problems. So we need to make sure that's under control, as well as things like chronic pain, heart problems, etc. This can all make mental health problems worse. And then if all that's been ticked off and we haven't really got anywhere, we need to consider that maybe the diagnosis is wrong. Remember the Trinity from before. The first step is to get the correct diagnosis. So let's make sure that is actually at play here. So for example, a lot of people will go to the doctors feeling depressed and they'll be not prescribed depression, quite the opposite. They'll be diagnosed depression when actually they may have something like bipolar disorder. Now, bipolar disorder, when it comes to medications, is a very different regimen than depression. So it's very important to really nail these diagnoses down. And there's also the chance that there's other, diagnoses playing on each other. So, for example, again, personality disorders, borderline personality can mimic bipolar, mimic ADHD, but often is comorbid with the other two. Now, if they're all playing their little part together to bring you down, you need to treat all of these individually. one size does not fit all. And it's very hard, and to give credit to doctors and clinical psychologists and psychiatrists, it is very hard sometimes to pry apart these different diagnoses because you're relying on the person, the individual, the client, to have that level of self-awareness and insight to be able to get across that there's more things at play here. And that isn't always a given. And for me, it took a very long time to get to that point. So if we've done all this, we've ticked all the boxes and it still ain't working. Now, I would say again, this is me. I've done all of these things and at different times I've ticked all these boxes, been doing it perfectly, and we still haven't got the results that we're after. There are some things that we can do moving forward. And it's very important, I think, that I say what these things are, because a lot of doctors and therapists either aren't aware of these new novel treatments or they don't support it for whatever reason. And I think that's wrong. So we're going to go into some of the new novel treatments that are coming out now, which have proven efficacy when it comes to mental health disorders. But the thing is, they're very new. They're a little bit different. So a lot of doctors, a lot of psychiatrists are not completely comfortable with prescribing these regimens, which is fair enough because they're new. We may not know the long-term effects just yet, but I'll tell you what, short-term, there is a lot of compelling evidence, as we'll see now. Actually, no, we won't see it now because I've jumped ahead. All right, let's go back to medication strategies. If you've tried an antidepressant and it ain't working, all right. So the first thing we can do is give the current medications more time. Quite often people will give it 2-3 weeks and they'll feel like things are getting worse, which is actually quite common, and will throw it away. Tell the doctor, I don't want to touch it anymore, and then that is the end of that. One thing that we can do is give these medications more time. Usually they say it's up to 4 weeks to see the effects, but I'm talking give it 8 weeks, give it double just to make sure that it's got the opportunity to do its thing. Okay, if that doesn't work, what we can look at is increasing the dosage, if indicated. So I'm not just going to increase the dosage for the hell of it. It's got to be rooted in the research and it's got to have been proven to help. So for example, Lexapro, I started on a low dose of 5 milligrams, which is pretty common. You can boost that upwards of 20 milligrams if needed. Unfortunately for me, it didn't work. But anyway, so if it doesn't work like it didn't for me, you can switch antidepressants. Now, remember I went through my medications, different classes. Selective serotonin reuptake inhibitors, like I said, are usually the first port of call. If they don't work, then you start to look at other types of antidepressants like the serotonin norepinephrine reuptake inhibitors. So switch antidepressant classes if needed. Now, if that doesn't work, you can actually add another type of antidepressant. So you can add a SSRI with, for example, an NDRI like Wellbutrin, although I've read a bit of research around this because I was sort of looking at if this was relevant to me. I've tried this before, didn't really work. It's not very conclusive. Some doctors will swear by it, but from what I can read, and I'm reading the journals that they're meant to be reading, the evidence isn't really conclusive. But anyway, for some people it definitely works, and like I've sort of said throughout this episode, it's very individual. It's very much dependent on how your makeup is. Okay, you can add a medication generally used for another condition. So, for example, these include antipsychotics like Seroquel is a popular approach. The mood stabilizers like lithium or lamotrigine. Anti-anxiety medications can be augmented with an SSRI like the benzodiazepine class. We're talking Valium there. And other things even like thyroid hormone. So remember, the thyroid, if it's not kicking in a gear, well, quite often depression is the result. But you may need more than just the thyroid medication. And the last thing, which is something I haven't actually tried and definitely have not been offered, is pharmacogenetic testing. So these tests check for specific genes that indicate how well your body can process a medication. Now, these aren't a surefire way to figure out what you need. You don't get the test and say, right, you need fluoxetine or Prozac. It's right here in your genes. It's not quite that clear cut, but it can definitely help. At least that's what the research says, because as I said, I haven't actually undergone that yet. Now, of course, psychology is very important, I think, to augment with any medication regimen. So very briefly, there's a lot of different types of psychotherapy that we can look at: cognitive behavioral, acceptance and commitment therapy, dialectical behavior therapy, all that sort of stuff, mindfulness. Really, let's look at a holistic approach, I think, when it comes to treatment resistance. And often psychotherapy will bring out the best in medication and vice versa. Okay, now let's move on to procedures that are being used, these novel treatments when everything else just isn't working. So let's start with something called repetitive transcranial magnetic stimulation, or RTMS. Don't worry, I will explain it. So RTMS in clinical trials is showing some great evidence, and one of the leaders in the field, the Black Dog Institute, who of course I have a strong affinity with and relationship with, they are doing a lot of research into this sort of stuff, and it is all good news. It is all good news from their end, which is great. So what RTMS is this. So it uses magnetic fields to stimulate nerve cells in the brain to improve symptoms of depression. So I think it's something like it polarizes, I'm going to get this wrong, but I'll go with it anyway. It polarizes the neurons so they're positive instead of negative or something like that. It changes the magnetic field or something about them. Okay, that was a terrible explanation, so I'll just move on. So what happens is an electromagnetic coil is placed against your scalp near your forehead, all right, so at the front. The magnet used in RTMS creates this electric current that stimulates nerve cells in the region of the brain involved in mood control and depression. So again, we're talking the amygdala, we're talking prefrontal cortex, that sort of stuff. Typically, the treatment takes about 30 minutes and it's delivered in rapid bursts, and it can be done over quite a long period of time, hence the repetitive nature of the therapy. So you don't go in and just do it once. It's got to be repetitive, but at the same time, the results are pretty good. And I'm sort of looking into it myself, to be completely honest. Another novel treatment is ketamine. Okay, so ketamine is a medication and that is often used recreationally, but is now showing benefits in the clinic as well when it comes to resistant depression in particular. The trials have started for anxiety as well. It seems to work for anxiety as well, which is great. So it's usually delivered through an IV drip in very low doses. So that's the difference with the recreational side of things. We're talking low doses here. The evidence, again, is very compelling. Rapid relief of hard-to-treat depressive symptoms. If you go to Google News and type in ketamine depression, you'll see a lot of stories of people who have had treatment-resistant depression really badly. And half an hour after treatment with ketamine, boom, they're this new person. It's unbelievable. So to begin with, again, it's repetitive. You don't do it once and then that's it. So the effects generally last from a few days to a few weeks. You're given dosages repetitively, like I said, over several weeks. Usually at the start, you do it not long after each other, and then the time frame extends from there. There's now actually a nasal spray formed called S-ketamine. Now again, the Black Dog Institute, the world's greatest mental health institute in the world, is leading the charge when it comes to S-ketamine. They're doing a lot of great trials down there as well, which is showing that this nasal spray form of the drug is working brilliantly. Usually it's delivered in a physician's office or in a clinic under the supervision of a healthcare provider, which is obviously to monitor for possible side effects, and because there is potential for abuse and misuse, as we know, being used recreationally. S-ketamine is for adults who have tried, generally speaking, it depends on where you are in the world, at least 2 other antidepressant medications. So really, I should have been having it years ago. Bring on the ketamine. Come on. So ketamine and S-ketamine work in the brain in a different way than standard antidepressants, but usually you use the ketamine along with an antidepressant. So really what they're finding is, so the brain has this neuroplasticity, so you can create new nerve endings, parts of the brain can become more dense and all this stuff, and you can prune other neurochemical pathways as well, depending on what's going on in your perceptual environment. But what they're finding is if you have depression, so there's the way the neurotransmitters connect is through these little, little branch things. Hopefully you can picture it. The synapses and the dendrites. And what they find is people with depression, these synapses and dendrites that connect and pass the neurochemicals like serotonin, norepinephrine, and dopamine, they actually wither away and die. And what they think ketamine does is grow them back. It's really amazing stuff. Really amazing. Like that is full on. So ketamine, really good stuff potentially here. And again, the research led by the Black Dog Institute shows great signs. And it is another novel treatment that I really want to be a part of. Okay, the next treatment we'll look at is not really a novel treatment, but they've really refined it and it's a lot safer than it used to be, although it isn't without its risks, is electroconvulsive therapy, or ECT. So if anyone has seen the movie One Flew Over the Cuckoo's Nest, you'll know all about ECT. Great movie, by the way. I'm amazed it took me this long. I literally only watched it like last week. It is like the movie for psychiatric enthusiasts, psychological enthusiasts like me. I can't believe it took me so long to watch it. Anyway, electroconvulsive therapy, which I might add is something that my grandfather actually had quite a bit of, and supposedly it helped him. But anyway, right, so ECT. So while you're asleep, a carefully measured dose of electricity, bzz, is passed through your brain, which intentionally triggers a small, brief seizure. I know, it sounds a bit scary. It probably is, let's be honest. ECT, they think, causes changes in brain chemistry that can relatively quickly change symptoms of major depression and improve them, generally speaking. Now, there are side effects. Like I said, they've sort of refined it a bit, but it's still, the whole brain's sort of getting shocked with electricity. You're having a seizure. This probably isn't very high up on my list, but anyway, we'll see how we go. Some of the side effects include temporary confusion or even temporary memory loss. And sometimes this can be long-term, although that is pretty rare. And again, usually this is done repetitively. And it seems to be able to provide significant relief of severe depression. So there you go. Okay, the last one is the one that I have least knowledge about, is vagus nerve stimulation, or VNS. So I'm just going to pretty much read this straight from the Mayo Clinic's website because I have no idea really what this one is about that much. I know a little bit about it, but anyway, we're about to learn more. So generally, VNS, vagus nerve stimulation, is tried only after other brain stimulation therapies such as ECT or rTMS have not been successful in improving symptoms of depression. So what VNS does is something like this. It stimulates the vagus nerve, which is around your neck region. I think it goes up your neck towards the brain with, again, electrical impulses. This treatment uses a device implanted in your chest that's then connected by a wire to the nerve in your neck. There you go, I was right, the vagus nerve. Ta-da! Electrical signals from the implant travel along the vagus nerve to the mood centers of the brain, which may improve depression symptoms. Again, we're talking about my favorite, the amygdala. Ooh. All right, so they are the novel treatments, or the treatments that maybe aren't the first line of attack. But there's the message really is, though, that if the antidepressants don't work, don't worry, there are other ways around this. And like I said, psychotherapy, if you're not engaged in it, is really something that I highly recommend. But as well as that, there's some other physiological type of interventions and other sort of medications like ketamine, which work as well. And speaking of that, another psychoactive drug, psilocybin or magic mushrooms, it is showing promise in trials as well for the use with depression. And MDMA, another recreational drug that's psychoactive, is showing some promise when it comes to PTSD as well. So the good news is antidepressants aren't the end of the story. There's a lot of things in the pipeline coming, which is exciting, especially for those like me, and I'm sure like plenty of you listening who are classed as treatment resistant. But I'll tell you what, one thing that we don't need if we're treatment resistant are governments getting in the way of healthy mental illness outcomes and prognosis. So let's go back to MDMA and magic mushrooms, psilocybin in particular. So just recently, Australia's medicines regulator, the Therapeutic Goods Administration, has rejected the call to legalise psychedelic drugs for use in mental health settings. Now, if there was decent reasoning behind it, I'd say, okay, fair enough. But really, when I read out the reasons for why they've blocked it, you're going to probably be left scratching your head like me, I think. So if you go on Google Scholar and search psilocybin depression, you will come up with huge amounts of research that says that this stuff is working. Now, this is what Australia's Therapeutic Goods Administration has said about the use of psilocybin. I agree with the committee that the preliminary findings from clinical trials, although still in the early phases, evaluated by the panel are promising. However, given the extent and issues with the quality of the completed studies detailed by the panel, I reiterate my statement in my interim decision that I consider that evidence is still emerging and the therapeutic value of psilocybin has not yet been established. Fair income. I am of the view that ensuring administration of psilocybin according to the strict protocols used in clinical trials that have showed promise of efficacy to date would be hard to achieve outside a clinical trial framework. Really don't know where they're getting the evidence for that from because they haven't given us a chance to try it. Now, like I said, if you go on Google Scholar, you will see so much evidence saying this stuff works. And I know I could count probably on two hands how many people I know that have tried this stuff off their own back and have got good results from it. So this is what the TGA come up with. I don't know who this person is. They don't name who this person is that comes down with these decisions. So this person is anonymous, but this is what they had to say. I am satisfied that psilocybin poses a high danger for both acute and long-term effects if abused or misused by way of access outside of strictly controlled medical and scientific research settings. The author of the final decision, who is not named, said, as I'm reading this from an ABC News article, given this increased risk to individuals of acute and long-term effects, a high level of control across the supply chain commensurate with Schedule 9 is warranted. So Schedule 9 means it cannot be prescribed under no circumstances. Schedule 8 is the first of the schedules coming down from the severity list where you can be prescribed. That's where the amphetamines tend to hang out. So earlier this year, another expert panel, I love these expert panels, commissioned by the Therapeutic Goods Administration, found that psychedelics could possibly be used to manage treatment-resistant mental illnesses in closely supervised medical settings. But because I bet none of these people have ever gone through what so many people like me and you guys listening have gone through, they are putting the brakes on, even though the research is quite overwhelming. See, there's an opportunity here for the TGA to really set the boundaries of treatment and really be a world leader with this stuff. But in true, typical Australian style, we are just too conservative when it comes to these things. So unfortunately, psilocybin and MDMA have been knocked on the head once again as viable treatments in this country, which is so disappointing because the research is very compelling. Very compelling. And the TGA had a great opportunity here to improve the quality of life of so many people, myself included. The thing is, what I don't get is this part about the long-term effects, if abused this is the quote again, or misused by way of access outside of strictly controlled medical and scientific research settings. I think they seem to forget that people have been using psychedelic drugs for decades. Honestly, you go to your local park, you can find sometimes magic mushrooms growing. Like seriously, they're out there. If people want to abuse these drugs, they are already doing it. And if people want to use them as medication to help improve their quality of life, they cannot do it through the proper means. And a lot of people I know have done it off their own back and have had great results. But I'll tell you what, it'd be a lot better if we could get a prescription from a doctor. And that's what I would like. But for me, if my prognosis doesn't really improve soon, because I've tried all these different medications, 16, I think it was, psychoactive medications with a whole raft of side effects, heaps of side effects, some of them that actually make my quality of life worse, you tend to get a bit desperate. And the TGA had an opportunity here to help people like me and like so many of you listening as well, but they knocked it on the head in true Australian style. We cannot be a world leader when it comes to this stuff. No way. Anyway, I'm going to get off my high horse. So that is treatment-resistant disorders. It's not all bad news. There's a lot of novel treatments out there. And although, for example, where we sort of finished on a bit of a negative there, the thing is the rest of the world's getting on with a job and Australia will follow suit. And for a lot of you guys who are listening from overseas, I know there's a lot of you out there doing just that. Thank you for the support. I do hope that at least your, medication administration group is a little bit on the ball than ours. But anyway, as I said, the good news is there's a lot of novel treatments that are definitely being used, and you need to just ask your doctor about them. Doctors, they need a bit of a push sometimes, and I think this is one of those areas where a push wouldn't hurt. So anyway, that's treatment-resistant disorders. It's not all bad news. There's a lot of different things that we can do. There are a lot of different medications, and it needs to be said too that although maybe medications haven't so far worked very well for me, they do work for a lot of other people. So it isn't all bad news. A lot of people do get an SSRI like a citalopram or Lexapro, and it seems to do the job. And that is great news. But for people like me that are a little bit more resistant to this sort of stuff, the good news is there's a lot of different avenues that we can go down. All right, so thank you again for listening. If you're enjoying the show, please like, subscribe, and share it around with your mates. That would be bloody awesome. And thank you as always for listening. And I look forward to your company on the next episode of the Dysregulated podcast.